last case, it's more actually clinical. Where did it come from? It's a bit a long case, but it's an interesting. This is a 20-year. This is your classic patient. A 20-year-old female presenting by edema of lower limbs, arthritis, rapidly deteriorating renal functions. Lab investigations showed hypertrophic microcytic anemia, high ESR, proteinuria 3 grams, her ANA were positive, long-strand DNA positive. The serum creatinine was 2, which jumped to, by the time she presented, which went above 4.9 in 1 week. So, very straightforward, rapidly progressive. Yes. So we did a renal biopsy. So she's lupus. We all agree that this is a lupus patient. Typical presentation, typical everything. With this clinical presentation, then which class are we expecting to see? 4, yes. And you can see here this glomerulus and H&E, and you can see the proliferation and there is thickening, more of a diffuse proliferative pattern. Then this is a trichrome stain, and you can see this is another cellular present with a trichrome stain. And as I told you in the beginning, with the trichrome stain, actually fibrinoid necrosis necrotizing region stands out. This bright red fucsin material is actually necrosis, and she had this foci, this necrotic foci scattered all through her biopsies. But she had also this. What is this? Do you know what is this? Yes, yes, this is a blood vessel. And what happened to this blood vessel? No, this is not hyalinosis. This is a large artery to hyalinosis. This is necrosis. This is non-inflammatory necrotizing lupus vasculopathy, which is an associated lesion with lupus. It's one of the associated lesions with lupus. It's very important to recognize it because then the patient, I think you give a different treatment, right?
هو دلوقتي حضرتك احنا قلنا ان ده نيكروزس على اساس ان البيت يعني في بليتنس في الارتري.
This is the wall of the artery, كله fibrinoid process. This is fibrinoid process.
Of the whole vessel.
Of the whole vessel.
Circumferential.
Yeah, she was amazing. It was circumferential. It was as if it was drawn. Yeah, I haven't seen it that regular. Oh.
You can't find that circumferential.
It was from Tango. Usually, vasculitis would be the differential diagnosis, but I need to see much more inflammation than this. This is non-inflammatory necrotizing, which is characterized with lupus vasculitis. So it really has no other differential diagnosis, especially present in a lupus patient with already a class 4. As I said, this was a patient from Tonga actually, and she was amazing.
والhuman يبقى completely free. يعني ده
This is in the wall.
But what's interesting about these is the rupture. That vessel cannot sustain.
Because there is no more wall. There is no more wall. The whole wall is
I expect some hemorrhages.
But there must be something.
There must be some. This is the section. This is the level of the section. And this is just the section. On another section, this is a smaller vessel, and you can see it full or complete.
What's peculiar برضه للإندوثيليوم is the nudity.
خلاص طبعا the necrosis. This is necrosis. No more anything. No more endothelium. No more edema. No more anything. No more. Probably she did not have thrombi anywhere. She had this lesion settled. Yes, she really phenomenal case. I did not. But anyhow, they released her, I think. Fluorescence, she had dense IgG and CT in the basement membrane, visual area, and weak IgM. Her IgA was not really significant. So she was lupus nephritis plus 4G and had an associated necrotizing lupus vasculopathy, which you need to put in a separate diagnostic line, as I said, because the nephrologist is going to manage the patient in a different way. The patient received aggressive treatment. Apparently, essentially, she took, I think, cytoxine. I think they released as well. And she had marked clinical improvement. She got married and had one full-term normal delivery with a healthy child. She was lost for a follow-up, but stated later that she had done regular analysis, we don't know why, but that they were normal apart from some albuminuria, which was persistent. 3 years after the first biopsy, she presented with vomiting and marked anemia. Probably she was non-compliant with the baby and everything. Her investigation showed proteinuria 2 grams this time. She had microscopic hematuria. She was markedly anemic. Her serum creat was 3.2. She had high lupus markers, and we performed another biopsy. This is the second biopsy. Again, this time the lesions are more segmented, and it did not involve all the glomeruli, and you can see the proliferation here. She had an early crescent here, and the rest of the glomerulus you see is more or less unaffected. This is an H&E stain, and with the pass, and I apologize for the quality of the pass, it just happened this way, but you can see that actually this glom is almost unremarkable, and you can see the segmental lesion and an early crescent here, yes. And that's another pass, again, with a beautiful segmental necrotizing region in one area, and 20% of the glomeruli were affected by this segmental proliferation, with the remaining only showed mild mesangial prominences. Her IF again showed the same pattern, and I diagnosed her as lupus nephritis class 3A. And actually, at this time, her chronicity was not that pronounced. I think she chronicity index was just 2/12 or something like this. Patient received again aggressive treatment, also with clinical improvement. Then 2 years later, she has slowly progressive deterioration of renal functions with minimal edema and marked hypertension. Her investigation showed mild proteinuria, serum creat 6 grams, severe anemia with mild elevation of PSR. Now they performed a third biopsy. Would you have biopsied the patient at that stage?
Yes.
Okay, good. And look here. First look at the tubulointerstitial. I always like to start with the tubulointerstitial because it's always the glans which takes our attention, and you forget to look at the other 3 compartments which are very important. And you can see the interstitial fibrosis. You can see the tubules starting to be affected. Look at this glomerulus and look at this collapse of the lobes here. And look in the trichome, even more apparent. Look at the interstitium here, all this green in between the tubules, and the tubule now is starting to be flattened and thickened tubular basement membrane, and we are getting to be really chronic. And look at her blood vessel, and as Dr. Mona shows you, this is just a PAS stain. But even with the PAS stain, you can see the number of elastic fibers, yes, very clear and apparent, and you can see the amount of elastosis with her hypertension. She had 25% of the glands were globally sclerosed, and immunohistopathology, the other shows segmental sclerosis. We did this time immunofluorescence was not done, and I diagnosed her with lupus class 2 with marked interstitial fibrosis and nephrosclerotic changes. She has no active features. She's good now. She's very down. No, that's the third biopsy. Fish crescent خالص. The sclerosis. Because only 25% were sclerosed. 6 you need over 90%. This is a very important point and a very good question. These classes are based on glomerular lesions. That's the problem always with the lupus classification, that it ignores totally the tubulointerstitial and the vascular compartment, which is the prognostic factors of the patient. And you look at the diagnostic line with the class, and if your pathologist just dependent on the fact that you're going to read the report and does not write to you in the second line, this patient has marked interstitial fibrosis, nephrosclerotic changes, then you're going to continue as managed as that this is class 2. So always bear in mind that lupus classification is glomerular. And this is not the basis on what we manage our patients later on, especially chronic patients.
How many glomeruli were there?
I don't really remember. That's an old case. Yeah.
Because you would argue like what's making the creatinine so high is just it's the chronic interstitial.
Yes.
Interstitial.
Yes, of course, it's the interstitial fibrosis and the nephrosclerotic. That's why her creat was high. It was not because of the activity. So it is not a matter. She is not class 6 because she does not have over 90% of her glomeruli sclerosed. but she is end-stage. But she is an end-stage renal disease. She was on dialysis since that biopsy on. So as we were all saying and we've been saying since we started the issue of lupus, that cases of lupus can pass from one class to another. These are classes and not stages of disease. So the patient doesn't have to go through all these stages. They are totally, as Dr. Mona just said, lupus has a mind of its own. Usually they move from better to worse, but this is not always the case. Sometimes regression to a lower, supposedly more benign class occur. You do get patients with class 5 and then they turn to be class 2, but beware of these patients. What's most important is that active lesions heal. And this is what happened. Her class 3 segmental lesions, although it was milder than the stage before, they healed. She ended up by being complicated by segmental sclerosis lesion. And that even in a lower class, the state of the interstitium and vascular compartment is what actually dictates the long-term prognosis of the patients. So in lupus, as a transplant, it is indicated to repeat biopsies whenever somebody in the clinical picture does not fit. Thank you.